Okie dokie. So, welcome everybody. My name is, oh gosh, let's turn off the transcript every time. My name's Laura King. I am a children's asthma nurse specialist, and I'm also senior children's asthma practitioner for North East London, which is a quite convoluted and unhelpful way of describing my job. Of supporting sort of everybody in North East London from community primary all the way through to tertiary care in children's asthma. And helping to embed the bundle of care. So as I've said, today's session is all about young people with asthma and MART therapy with a real focus on MART and air, specifically in the new guidance. I'm going to start very quickly with a quick glossary. So one of the reasons I asked for feedback is because it helps improve the next session. And in the first and second sessions, I had a couple of comments that I'd use shortened abbreviations a little bit too much, and I am very guilty of that. So here's a little glossary. So air, anti-inflammatory reliever; MART, maintenance and reliever therapy; SABA, short-acting beta agonist, so i.e. your salbutamol, formoterol, your quick-acting medication. And that is my worst contender. I will say SABA, and I just can't help it. I'm sorry. So SABA is salbutamol. ICS, inhaled corticosteroid; PAP, personalized asthma action plan. I will probably call it an asthma plan, so that's easy. PMDI, pressurized metered-dose inhaler, and your bog standard inhaler and spacer. I've just realized I don't have with me, so I'll just reach for my sons as I'm talking. And a DPI, of course, is a dry powder inhaler, so that's pretty much anything that's not one of these. Aims of today's session. So we are going to be considering optimization of asthma therapy, of course, with a stance on air and MART, but we're going to start with the brilliant basics of asthma care. We would like to understand the implications of adolescence on asthma. Oh, a typo, lovely. And vice versa, so the impact of asthma on adolescents. We would like to introduce MART therapy for young people aged 12 plus. And we're going to consider the place of MART and air in your practice. And we will have some time at the end to consolidate all of the above with some case discussion. It is going to be quite a whiz through. There is a lot to cover. And I'm really mindful that it's only an hour session. But as you know, it's pretty hard to collar people when you're all super duper busy. So if you have any questions, either put your hand up or pop it in the chat. I will just open the chat now so that it's open. And feel free to dip in as well. If, like I say, everyone so far in the last 7 sessions has had really valuable experience, really valuable insight. This is meant to be informal. Please do dip in. I really appreciate it. And I've had for a lot of my sessions, I'm just going to flick through the attendees, some of my colleagues, some of my specialist colleagues, which is always really helpful. I'm not going to be mean and sort of put them on the spot, but it's been really fantastic to sort of have everybody on board. And those of you, sorry, that are new, just joined, please can you just pop your job and where you work in the chat just to keep me up to date with who's coming. So without further ado, let's get started. Like I said, it is a bit of a whiz through. Before we do any sort of asthma learning, we talk about optimizing any sort of asthma therapy or making changes. We need to make sure that we are covering what I like to call the brilliant basics. So some people will call these fundamentals. It's quite often referred to as the 5 pillars of asthma care. Maybe that's just me in my nerdy little asthma world, like calling it that. No problem, Mina, don't worry. These are the 5 brilliant basics. And if anyone's ever sort of read any of the bits and bobs from asthma and lung or some of the bits that we've written, it will quite often be called this. So number 1, understanding asthma. So first and foremost, if you don't understand what asthma is, i.e. inflammation, at any age, you are very, very unlikely to manage it well and be well. I see quite a lot of young people in my clinic and children. I kind of use those words interchangeably, and I am sorry because it is about young people today. I've worked all the way through from primary through to tertiary care, and I'd say probably a good chunk, maybe 80% of all of those children and families at whatever point, if they are struggling with their asthma control, a lot of the time it comes down to one of these fundamental things. And a lot of the time it's understanding asthma. They actually just don't know what it is. And it's really challenging to think, gosh, they've had all this education. I have no doubt that people have sat and explained it to them. It's just something that's not very well retained. They say it takes about 7 times of repeating information to embed it. Number two is understanding how and why medicines work. So again, you could understand what asthma is, and that is fundamental. But if you don't understand how or why your meds work, you're very unlikely, again, to take them, adhere to them, use them well. Certainly as a parent, I've got two young children. If I didn't know how a medicine worked or why I was giving it, I'm very unlikely to give it to my children. That's just a fact of life. And we want our patients to be empowered. We want to make sure everybody feels confident in how and why they're going to be giving meds. So next in line is inhaler technique. Probably should be called device technique because we're talking about lots of different devices today. Again, I kind of feel like they're going from one to the other. You can understand asthma. You can have the best medication in the world. You could have the most beautiful prescription and the best, the best doses, the best devices. But if you're not using them correctly, it's kind of not worth all the hard work. And I will quite often say to young people, recognizing their effort, for example, a young person who's taken the medicines beautifully, they're remembering every day, and you say, oh my goodness, well done, you should be so proud of yourself for remembering, but you're not using a spacer, or you're not doing this, or you're using it in a bit of a suboptimal way. All that hard work that you're doing, and it is fantastic, is kind of pointless because it's not getting from here down into your lungs. And a lot of the time, even with our older young people and parents, quite often we'll kind of talk to the child, but actually I'm sneakily trying to educate the parent. I quite often will explain the airway in a very basic way. The medicine is going in your mouth, then it needs to get round the bend and down into those little tiny airways. If we're firing a PMDI, it comes out 70 to 90 miles an hour. You need to slow it down. If you're doing one of these, you need to hoover it in. And it's kind of those really clear descriptions that really help, in my experience anyway. Back to the brilliant basics. So number 4 is having an asthma plan, and that's any kind of asthma plan. And I know in North East London we generally gravitate towards the asthma and lung one because that's what our systems kick out. But there are beat asthma plans. We will soon have a pan London asthma plan, which will be on the KEG template very soon. And there are of course specific MART and air plans as well. And again, there's more than one of those. So essentially, they tend to be traffic light systems. Green when I'm well, amber when I'm niggling, red I'm in trouble. They generally all work in that sort of format. So I will be a little bit controversial and say I don't really care which one you use, as long as you are using one and your patient understands it. And similarly, number 5, and again, this may well even be the most important one for lots of our families, knowing when to seek help is such an important part of asthma care. If they know when they're in trouble, first and foremost, when they're having an attack, obviously that keeps them safe, but knowing when to seek help in a non-urgent way. So when their symptoms are niggling, when they're not sure about their treatment, they're not sure how to use their inhaler, they've got a new device, they're doing a bit of troubleshooting, really important. And then lastly, but certainly not least, something to consider when we think about all of these fundamental aspects of care, which quite often we find in things like death reviews, are called sort of modifiable factors. The young people that are most at risk of dying from asthma, at the sharpest end, it would be quite easy to think and assume that they're sat in the high level, severe, difficult asthma clinics, on biologics, on all the fancy medicines. But actually, the evidence tells us that the most at-risk young people are those that are considered mild, and I'll use that in inverted commas, with poor control. So what I sometimes call sort of the unknown, unworried, unwell, those young people who perhaps, if this is not a diagnostics talk and we're not going to go into it today, but those who perhaps are not coded as asthma, not diagnosed formally, maybe treated but not diagnosed, maybe treated, maybe not, and sort of niggling, and they're not on anyone's radar. They're the ones that you want to worry about. And this is actually where MART is a really fantastic regime, because it is quite risk averse and it is a real safety net. So if we don't have any questions at this point, I'm going to start talking about young people and adolescence as sort of a life stage. So when we're thinking about regimes like MART, it's really important to understand the context of the age group. So when we're considering the young person, so age 11 onwards, so for all purposes, sort of secondary school age, we want to consider them in the context of their development. It's a journey. There is a sort of a spectrum in terms of where they are in terms of their development. Hopefully this slide is helpful to you. It's something that I've had in a training session myself in a different form, and I found it really helpful. So on this page, you can see on the left, it's almost sort of a spectrum of development. On the left, we've got younger children, they're concrete thinkers. And on the right, we've got our sort of fully developed, I suppose, young adults, if we think about the neurotypical young person, of course. So when we think about where people are, it's important to understand where they are on this spectrum. So on the left, we've got young children. So small children are pretty much concrete thinkers. They have very basic self-awareness. When you are a very small child, there's a point in very young childhood where you actually think you are still part of your parent. You then become sort of psychologically realize that you are a separate person. And the sort of self-awareness then develops from there. In terms of the concept of their body, as you'd imagine, the youngest children and even up to sort of young primary school age children have quite an interesting concept of their body. They almost see their torso as one big blob. They don't really differentiate between chest, abdomen. They draw these potato people for a reason, these big blobs with arms and legs stuck on. And as they grow, the neurotypical child will learn more about their body. They'll learn how things work. They will obviously understand a bit more fully, how they're built. And of course, as they go to school and learn, the basic biology, they'll understand a bit more about how their body works. Basic understanding of breathing, which then moves on to a more in-depth understanding of breathing, which we can use. We can absolutely use that when we speak to our young people. How do you understand breathing works? What have you learned in school? Do you know where your lungs are? Really important. Do you know that your lungs are attached to your mouth? Also really important. We talked about the idea of inhaling medicine. Do they realize that they have a tube that goes sort of around the bend, in a very basic sense? But while these ideas of how our body works develop, we also have this emerging sense of self, this emerging sense of sort of who they are, their own development, being able to think in sort of a more abstract way. So in terms of their actual development, their cognition, we're also moving from this real concrete thinking where things are very black and white. And I don't know if any of you have young children, it can be quite tricky to navigate life with a child who doesn't understand the relationship between behavior and consequence. I've certainly been in that position this week. They move sort of through adolescence all the way through to this idea that they can think in a completely abstract way. So they go through this huge, quite difficult time where they sort of start to understand things like risk versus benefit. They can understand more abstract things, like the idea of inflammation is actually quite an abstract concept. You can explain it in the best way. You can talk about red, sore, angry, like eczema. You can talk about the airways. You can show it in the pictures, but actually it's something you can't see. It's quite a tricky thing to understand sometimes. And again, this whole ability to think in an abstract way is super important when we think about concepts like MART. We are talking about prevention at the same time as treating symptoms, and it can be quite difficult for some people to understand. And we've also got the inherent risk of having asthma and having inflammation versus treating it, which again can be really difficult. As I've said, adolescence is a I could talk about it all day, to be honest. It's a fascinating time of life. It can be very tough. I listened to a podcast the other day where a psychologist said it's adolescence in terms of brain development is second only to the first year of life in terms of how much is happening, which actually really surprised me. And she described it. I put the link in the chat actually because it was so interesting. But essentially, the whole brain has to reboot, update, whatever you want to call it. It can't all go offline at once. This is what she said. So the brain has to do it in series. So bits of the brain, bits of the neurology will come offline. So that's where we get things like mood swings. We get our young people who suddenly think they're invincible. We get this real risk-taking behavior. And as I've said, these whole systems go offline. And again, it can be really difficult as a clinician to have these consultations when you're actually not sure where you're at. So this is obviously important in any therapy, but as I've said with MART, it's particularly important because it's a new way of thinking. So if we think a little bit more specifically about things we can do, so specific problems related to adolescence and things we can do, we've got the brain development. As I've said, we're moving from the concrete to the abstract. We're talking about we can do this and the consequences will be this, or the idea of risk benefit. we've got this period of time where we've got really high impulsivity. We may have risky behavior, and that could be risk taking in the sense that you'd imagine, with teenagers, but it could also be risk in the sense of, I'm going to stop taking on my medication. I'm going to just completely ignore all of the advice that's given to me, or just purely a poor understanding of the consequence. For example, I've not taken anything for ages. I haven't died yet, therefore it's not going to happen. Or my friend didn't do it either, and they're fine too. So what can we do? We can educate. We can help them understand what asthma is, of course. So think back to those 5 pillars. We can help them understand what the medications are doing. We can sort of reiterate it. We can repeat it as much as possible. They say it takes 7 times. If we're all saying the same thing, it's really helpful. And we can help them understand the inherent risk. We can support them in understanding the risk versus the benefit of taking therapy. And we can clarify that it applies to everyone. It doesn't matter who you are. If your lungs are inflamed, it's everybody. Next, in terms of things, and these are just as important as all the others, hormones. Don't need to tell anybody in the room how important hormones are during adolescence, but they can be a significant trigger for asthma, both developing and worsening. So for some young people, adolescence will be the time, or puberty will be the time when asthma first becomes a problem, symptoms first become a problem. But for young people as well, that period of time, for children who already have asthma, it can become a lot worse. And one of the really classic examples of that is young women in the perimenstrual stage. So when they're starting their periods, or on the first bit of their period, so the period itself, day 1, can be a real problem. The fluctuations in the in estrogen and progesterone can really trigger symptoms. So for some young women, they will exacerbate their period as a trigger for their asthma, and it can be really embarrassing. They find it really difficult, and I've certainly had patients in the tertiary service in various jobs where we've really scratched our heads about what the trigger is. We've done everything we can think of, really fancy tests, home visits, lots of allergy testing, and then we suddenly realised it's every 28 days, and the poor girl was just embarrassed to tell us that she'd realised it was her period. Historically, the female hormones haven't been really that well researched, so we have this emerging sort of body of evidence that the female hormones are really significant in asthma, and that's why we get things like pregnancy asthma. We get lots of problems with asthma during menopause. So if you're somebody that works that has an interest in women's health, it's certainly something to be aware of. And it's not that well known either, so it can be quite difficult. In terms of adolescence as a point in time, when we're thinking specifically around sort of early adolescence, when the young person might be moving from primary to secondary school, so that's sort of 11, 12 age, depending on what schooling they're in, suddenly there's this difference in what's expected of them. A classic thing is that when you move from primary to secondary school, you're suddenly expected to carry your own inhaler, your own AAI, EpiPen, Jext, whatever. You have your own plan. And that's quite a big change for a lot of our young people. They're suddenly going from a primary school to a huge secondary school. It can be really difficult. But it's also a really good opportunity to start supporting self-management in a really tangible way. So, life skills, understanding, of course, what your condition is and understanding what you need to do, understanding medicine, but also navigating the system, understanding how to order a repeat prescription, for example, what to do if you need an appointment, doing an e-consult, using the NHS app. They are things that perhaps a parent might have done for them in the past. So I would encourage you to start small, start planting the seed quite early, get them to consult with you for a short time without the parent if they're comfortable. I will quite often with young people, if I feel like it's appropriate, kick the parent out for a minute and say, we're just going to have a chat on our own, just to get them used to it. Really, really helpful. And again, it sort of sets them up, and we set the bar high. We're not setting the bar low for our young people. We ask about their plans for the future. We ask them how they navigate the system. We ask them what they are doing to look after their own health, and absolutely putting the onus on them. They are the decision makers. And then finally, we've talked about this already a little bit, but we've got this desire for independence. It's really a strong desire for independence and sort of being your own person, forming your own belief systems. And it can quite often be at loggerheads with their desire to be accepted by their peers or socially, finding their sort of place in society. We are in a multicultural, incredibly diverse patch in North East London. I know I've got colleagues from elsewhere, but I'm sure you have the same thing. Sometimes for young people, their peer sort of perceptions of things and their peer values and beliefs might really be at loggerheads with their family's beliefs or their community or their culture's beliefs, and it can be really difficult. Something that I was made aware of quite recently was this phenomenon called the invisible audience. I used to think when I saw a young person in clinic, especially the really stroppy ones who are, I must say, some of my favourite patients, that, I don't want to use spacer, I don't want to do this. I'm absolutely not going to do that, Laura. Not going to happen. I'm not going to use a spacer in front of my friends for football at school, etc. And I'd think to myself, oh, it's okay because in private they'll do it. In private they'll use their spacer because no one's watching. No, it appears there's this sort of subconscious phenomenon even where for lots of young people, they sort of feel like they're being watched subconsciously, obviously, otherwise that would be a whole other kettle of fish psychologically. They're being watched all the time. So actually they may not behave in private the way you'd expect them to either, or the way you would like them to. And again, this makes the choice and sort of these various different regimes much more useful, much more appealing. So that's sort of a bit of a whiz through adolescence as a phase. And I realise I've talked about it for quite a long time, but it's really important when we think about, we're sort of priming, we're sort of looking at the cohort we're considering for MART with an idea of actually what's going on, where we're coming at, and where that young person is in their development. So MART and AIR, what are they? MART, of course, is maintenance and reliever therapy. So it is essentially one inhaler to all them all. AIR is anti-inflammatory reliever. You might call it AIR, you might call it AIR therapy. What's the difference? So MART, as I've said, one inhaler for everything. Maintenance or preventer and reliever. And in adolescence, so for young people age 12 and over, the licensed device, on-label device, is Symbicort Turbohaler. So we're not being biased. That is just what is licensed. My understanding is that hasn't changed yet, that it may well do in the future. I know there are other ones for over 18s and over 16s, but we're talking about 12 and over here. AIR is where we don't have a preventer per se. We use our combination inhaler. So of course, Symbicort is a combination inhaler. We just add formoterol. And you use this instead of using your blue inhaler and spacer, we should probably say, we're using this instead. You reach for your blue inhaler, you'd be using this instead. Hopefully that's clear, because we've had loads of questions about this. It's really quite a new thing to get our heads around, certainly in paediatrics. So to do a bit of a visual representation, because I quite like a visual, MART therapy, we have our morning dose, which is 1 or 2 puffs. We have our evening dose, 1 or 2 puffs. And then up to 6 additional doses per day as sort of rescue doses, 1 at a time usually, but you can take up to 6 together. AIR therapy, we of course have no preventer. There's nothing in the morning, nothing in the evening unless you're symptomatic. And then we have up to our 6 doses again. So of course our young person may use all of them. They may use 1, they may use none. That's sort of how it works. And I realise that actually for a lot of you are primarily adult focused clinicians, and this is not new to you. In peds, we are a little bit late to the party, and it's taken us quite a while to get our heads around this. And similarly for our children and families, if they are really set on or very emotionally attached to their blue inhaler, which we'll talk about in a minute, it can be a real tricky change. In your turbohaler, you of course have, excuse me, let me just click over, 120 doses. So if somebody is well controlled on MART, and they are only needing their preventer doses, so the morning and evening, if you're 1 puff BD, it will last 60 days. 2 puffs BD, it will be 30 days. So again, it's a good timestamp to think about whether your patient is well or poorly controlled. If they're needing more rescue doses, they're going to need a device more often. We'll touch on that in a little while, but if you imagine that the guidelines say something like if you're needing more than 3 doses a week, additionally, that would be what, 12 a month. So again, that request for a new one might just come a little bit, a week early, for example, at best. Where does MART fit? So it's not a new regime, as I've said. We're quite behind in peds. To be honest, it's well established in adult care. And I know that a lot of my adult focused clinicians are already super hot on it. It's just that confidence with young people. The national guidance, as I've said, has just come out. We've got the joint BTS NICE sign guidance that came out just before Christmas. But actually the international guidance, so GINA, for example, has promoted MART therapy for quite a long time. Again, they've been a bit ahead of us, to be honest. And of course, MART has a very clear place in the newest guidance, which is the one you can see on the right. I'm sure it's not news to anybody. We've been waiting for this guideline for flipping ages, it feels like. That it really puts it front and centre in all the algorithms. So I'm just going to have a little sip of water if you just have a look at the algorithm. This is the pharmacological management of young people aged 12 and over. So personally, there's a few things about this algorithm that I really like. So first and foremost, I really like the fact that it says kind of all the way along, I'm trying to find it because my presenter view is tiny. If asthma is uncontrolled, we offer. If asthma, it identifies if you're well controlled, you can stay on that rung. If you are poorly controlled, we step up. Although when this sits down, see that we're stepping up methodically. I also really like that there is a recognition that there is a cohort on effective preventive therapy as per the old guidance that they're using, are happy with. We don't need to mess with them if they're well controlled. And I like that because I think whenever something new comes out, it can be quite easy to jump the gun and suddenly start blanket switching people. That's not what we want to do here. Yes, of course, you can have the slides. I actually forgot to put them on the chat, but I will do that. I had a fiddle with them earlier. That's why there's a typo. Note on here, we've got the low dose and moderate dose MART. We'll talk about that in a minute when we look at the equivalence and the dosing. If we look at the two sides, I suppose, to this flowchart, though, we've got on the left, we've got patients who already are diagnosed. So they're the patients that are already on your asthma register. They're already diagnosed. They're not new. And it looks at essentially, are they SABA only? If they're SABA only, really, we should be considering basically air therapy. Really, we shouldn't have anyone on just SABA or salbutamol. Sorry, see, I've done it. We shouldn't have anyone just on this. If we are thinking it's asthma, we should be preventing. So again, that's a really helpful thing to be thinking about. If your patient can use a turbohaler, we should be moving them onto air. If they're diagnosed and happy with their treatment and well controlled, we don't change anything, of course. But if they are on these sort of two rungs, so we've got what we call the low and moderate doses, and they are uncontrolled, we would first and foremost be considering, would they be appropriate for MART? Can they use the device? And we'll talk about who would be moving on to it in just a minute. But yeah, I really like the way it steps up. So, and then for your newly diagnosed asthma, of course, we're asking clinicians to consider MART in the first instance. So first and foremost, we've got this box here, which I really quite like. In the first instance, if you're diagnosing them, now you would imagine anybody that's going to be newly diagnosed is having symptoms. So I do feel like it is a little bit obvious. If they are already symptomatic or there's severe exacerbations in the past, we offer low dose MART straight away. So there will be a group of patients coming up that actually will never have a blue inhaler. And just a bit of an aside, if you do have a patient that's newly diagnosed or you've just diagnosed and they have a history of severe attack, that's actually the most predictive factor to have a future severe attack. So it's just to be really mindful that we do need to be really cautious. We do need to make sure they have this safety net of prevention. In my teaching role, teaching on the Tier 4 course, my area of expertise is sort of the acute and risk profiling, and they really are the highest risk patient alongside the ones who have food allergy. So really do bear in mind you can always step someone down later on. And as you can see, if asthma is controlled, we consider stepping down. So as you can see, we've got this straight over to low dose. If they're uncontrolled, we go up. Hopefully that's clear. And then, as you can see, the green box is a sort of symptom release. So in the old money, I suppose, we've got a salbutamol plus preventer. In this one, the only symptom relief option is air. So where we're using this as relief. As I've said, when we're thinking about when to be concerned with patients, particularly ones that are on air, but also the ones using MART, there's a little box in the corner that talks about how we would identify uncontrolled asthma. And it's very similar to what we do already. We would perhaps say to our patients, as per their plan, if you're needing your reliever more than 2-3 times a week, please seek help. It's the same here. So it says something like, I can't read it on this box, but any patient needing oral steroids, absolutely red flag. We would want to be reconsidering adherence, reviewing them, and potentially stepping up if needed. Or frequent regular symptoms and needing their reliever 3 or more days a week, we would revisit, and we would call that uncontrolled. When we think about our ICS equivalents, as I've said, we've got the low and moderate doses here, and we're going to talk in a minute about the Symbicort, particularly the specific Symbicort dosing regimes. When we think about ICS equivalents, this is an excerpt from the guidance. I don't know if you remember the NICE and the BTS used to have a slightly different way of categorizing ICS dosages. I will admit I had the BTS one printed and stuck in my diary because there were so many inhalers and I wanted to make sure I had the equivalents right. It's not always obvious. This is quite helpful, I think. So if we're thinking about particularly here, we've got our, for example, we've got our budesonide DPI here, 2 to 400 micrograms. So essentially, this is where Symbicort sits, basically. 2 to 400 micrograms of a budesonide DPI, i.e. a low dose, is equivalent to a Sopra-Beck 100 or a Clenil 102 plus BD. Similarly, we've got Seretide 125 would sit sort of here in this column, moderate dose, and Sopra-Beck 200, 2 plus BD would be, yeah, here. Sorry, I was just making sure I didn't do an arrow. Something to bear in mind as a bit of an aside, I know it's not that common or that popular, certainly in our patch. If you have a patient on QVAR, don't forget that because of the size of the particles, it's sort of worth double in terms of the steroid load. So QVAR 100 is worth a Clenil Sopra-Beck 200. Lots of people aren't aware of that, so I thought I'd just drop that in. So when we think about our guideline and the impact, what does it mean? I will admit I completely shamefully copied and pasted this from a webinar I did on the new guidance a little while ago. So for existing diagnoses, if they're well controlled, they're happy with their treatment, and they're using it well, of course, nothing. We're not going to change them. They're happy. They're fine. We don't need to be messing around. But if they're control suboptimal, or there's problems with any of the modifiable factors, they're not using the device, they're not adhering, they're not using it well, we would consider MART and consider their appropriateness for MART. And for new diagnoses, again, we would be considering MART in the first instance. And as I've said, there will be patients who never have a blue inhaler, which wouldn't that be just strange and brilliant? But only again if they can use it successfully. And again, we will talk about that in just a second. Like any other treatment, when we're changing devices or changing the way we do things, we would be wanting to assess our patient. Now, what this doesn't mean is it means we are not going to be blanket switching everybody to the new recommendation. This is not a Clenil to Sopra-Beck. This is a completely different way of working. And we're certainly not going to be switching anybody to MART or to a turbohaler without acceptable assessment of ability, technique, understanding, assessing their respiratory drive, and their ability to do a MART regime. I've got a link to, I think, in the chat, but there is a really fabulous switching tool on the PCRS website. And if you're not a member already, I'd certainly recommend it if you're somebody that does a lot of respiratory. They've got a really lovely infographic on the new guidelines, and it's really helpful. It's for all ages. I found it really useful. I've certainly used their resources myself. What does this mean in terms of Symbicort? So again, I will absolutely admit that this is another thing I have tucked in my diary. I have it here. AstraZeneca will send them to you, actually. They're really good for your clinic room wall. These are the devices available and the dosage guide. So I'm just going to use my paper one because my presenter view is rubbish. We've basically got 4 devices. We've got Symbicort 100/6 turbohaler. We've got a 200/6 turbohaler. We've got a 400/12, which I'm actually just going to ignore for the purposes of this because it's not actually very helpful in this instance. And we have got a Symbicort 100/3 PMDI, but again, we're not going to be talking about that today. There's lots of evidence coming out about their use. I think the new guidelines and the new bundle of care are going to talk about it a little bit more. We are talking today about MART therapy with a turbohaler. And as you can see, actually, the doses aren't quite equivalent, and it's just a bit complicated. It can get a little bit messy. So we're going to be talking about young people. As you can see, ignoring the children part because we're talking about adolescents. Adolescents, we've got 3 columns. We've got maintenance here. So you can, of course, have a turbohaler just for your preventer, and you could have a different kind of device for your reliever. And for that, you can have either of the two. You can have a 100 or a 200. Again, 1 to 2 plus BD. Moving on to the MART, though, again, if you remember I'll see if I can scroll back. If you remember our flow chart, we've got the 2 sort of categories. We've got moderate and moderate to severe. Moderate asthma, we will be looking at a 100/6, 1 to 2 plus BD, again, as per the flow chart. Moderate to severe, again, we're going up to the higher dose. Again, it's that stepwise therapy that we're really familiar with. So either of those can be used for MART, and it's a bit of a judgment call clinically around which you'd be doing, but there's lots of resources around to help. If you're doing AIR, so anti-inflammatory reliever therapy, i.e. only using this for a reliever, not a preventer, the choice has been made for you would be a 200/6. So it is something to be mindful of when you are thinking about how your patient might use the device. It's a 200/6 always. Again, I popped the details for the contact for AstraZeneca because they do provide some really helpful resources. Hopefully that's clear. I'm just going to chat. I don't think there are any questions. Lovely. We've had some really fantastic ones over the last few sessions, which has made me sort of be a bit more careful about how I word things. Going back to our brilliant basics, if we're thinking about all of the things we've just talked about and the fundamentals to be sure of when we're changing therapy specifically to MART, what are we going to be most concerned about here? We've had the history, we've talked to our patient, we've assessed sort of where they're at in terms of severity. We're thinking they might be appropriate for MART. What would we want to be checking? So we'd want to be checking, well, all of them, to be honest, but we want to be checking they actually can use it. Do they have a good inspiratory drive? Can they actually use the device? But we also want to know whether they will use it. You know, they say the best device is something the patient can and will use. But we also want to know that they actually know how the regime works. So understanding their MART plan, understanding the difference between MART therapy and preventer reliever therapy, and of course knowing what to do and know when to seek help. And when we think about understanding it, it can be, as I've said, with young people, it can be quite difficult, and it's quite easy to make these assumptions that they just won't get it. Yes, our young people need to understand what asthma is. They need to understand that it's inflammation. They need to understand the concept of prevention over time. You know, we've talked to most of our young people a lot about preventers and why we take them. But again, the idea of having one inhaler for both, you know, we could assume that it's quite difficult. And then we see things like this, where we have targeted marketing for young people. Yes, this is skincare, of course, but we have this bright green cream that is literally marketed directly at young people on social media. You know, I'm not that young. I just had an early morning scroll. Sadly, I'm not a young person anymore. It's green, and the whole selling point is that this cream deals with your underlying skincare issues while actually covering it up and making you look very lovely. You know, young people can understand that. We are perhaps doing them a disservice, assuming that they won't know. So I would just encourage you to give them the benefit of the doubt. It might be that actually you need to plant the seed early, and next time they see you, they might have made the decision. But it's really important, and that ownership of the choice is really, really vital. So after understanding, we want to make sure they can actually use the device. So I've got a placebo one here. Hopefully you can see that. Again, I put, I think, in the top of the chat, I popped, or this bit of the chat from today, I popped the reps details in. Really happy to send them. Not biased, it's just what's licensed. So we've got this lovely placebo, and actually the real one isn't see-through, but this one is. So you can see that we've got the mouthpiece, we've got the twisted bit at the bottom, and we've got a dose counter. If you can see that, it's here. What's really helpful about the dose counter is it will go red when there's 20 doses left. It's a bit like if you've ever been somebody, you know, in retail, being a Saturday girl, it's like your till roll going red. So first and foremost, we'd get them to remove the cover, which I've done. You unscrew it, don't pull it, because it'll break. We check the mouthpiece is clear, and we check the dose counter. So I've got about 100 doses left because this is quite a new one. We're going to hold it upright, and we're going to twist it till it clicks and twist it back. Now, this is really important in terms of holding it upright, because inside this is like, it's a bit, I used to say to my young people, it's a bit like a Pritt stick. It scrapes off a dose. So if we're holding it sideways, it's just not going to scrape it very well. We hold it upright, we scrape it. We get our young person to blow out away from the device. We get a good seal, and we breathe in really hard and fast. And then we ask them to hold their breath for a few seconds. And as I've said, what I quite often say to my young people is, you know, your PMDI is coming out really fast. It's coming out 70 to 90 miles an hour. We need to slow it down to get around the bend. That's why we're so naggy with you about spaces. With this one, you're hoovering it in and you're hoovering it around the bend. And sometimes that's just enough to get the narrative that they're breathing hard and fast. And there are some really great videos. I think I've already put it in again in the chat in my list of resources. Asthma and Lung have some really fantastic ones, but also there's an app and a website called Right Breathe, really fantastic for any device. So I think they have every inhaler that's licensed in the UK on there. And then also we have these training devices, they're single patient use. Very similar, as you can see, it's just the middle bit. You know, we can't be giving these to every patient to put in their mouth, but we can be using these. These are clean. So they do click, And if they do a good enough inhalation, it makes a noise. And then we can see that they have a good inspiratory drive. Obviously, we also have to make sure that they realise it's not going to make that noise for real life, because that would be rubbish. Good tools to have, it's good for them to actually see and feel what it's like and understand that they are doing it well enough. Moving on a little bit, so we've established that our patient can take the MART device. We want to make sure they understand the principle. So we've got our MART action plan. As I've said, it's like any other plan in that it's a traffic light. So green when I'm well, amber when I'm niggling or need to seek help semi-urgently, and red in an emergency. So this is our patient details. I've obviously filled it in. I've been a bit of a nerd, to be honest, but there we go. We've got Ron here. We've got his peak flow in. So again, there's lots of iterations of MART Asthma plans. Lots of them will have peak flow. The Pan London one, which is coming, I believe, will pre-populate the peak flow when it's available, and that will be shared with you via the network. We've got in the green, I've just realised you can't see my laser pointer, sorry. Here's the peak flow here. In the green section, we've got, first and foremost, as with any plan, this is my preventer. This is what it is. This one has a picture, but that's obviously because it's made by Symbicort. It'll either be, like I say, a 100 or 200/6. All my illustrations are 100 because I didn't think to make 200. We have one puff in the morning and one puff in the evening, and obviously for some patients it'll be two. This is my preventer. I do this even when I'm well, and we really push that narrative that we do it every day. This sort of keeps us well. And then for my reliever dose, like you would have in a bog standard asthma plan, if I'm feeling a little bit tight, if I'm coughing lots and lots, blah blah blah, I might use 2 puffs on my blue inhaler. For my reliever dose, we take 1 puff at a time, up to 6 puffs. And then at the bottom, we've got a description. My asthma is well controlled and actually, if I'd filled this in properly, I would have had the person's personal best peak flow at the bottom as well, which was 450. Amber, of course, is increasing symptoms. So we've already seen all the guidance. If we're needing to use our reliever more than twice a week, we would be wanting to seek a little bit of help in terms of, my symptoms are niggling. I might need a bit of a step up. I need some advice. We've also got some very clear advice here about when. So I need to contact my whoever within about 2 to 3 days. So, sort of semi-urgently. I will do this if I am having these symptoms and my peak flow is whatever. So for this person, it might be, it's 375, whatever. Or I'm having these symptoms. And actually you can add advice. So for this young person, and we'll talk about it in a bit, they would be trying peak flow readings if they're unsure about their symptoms, they're unsure about where they're at. Try some peak flow readings, see actually where you're at. We know their best is 450. It's a really good measure. We're comparing like with like. And then red, unsurprisingly, red is we are in trouble. It's an emergency. These are the signs of an asthma attack. Again, you would say, you would be putting in the right peak flow if that's something the patient uses. And if I have an asthma attack, I should do X, Y, and Z. Something really important to do, but I'm sure you already are, is making sure that we are seeking help if we are needing our rescue doses. So if we're needing to use our 6 puffs of our turbohaler, for example, and we're not winning, we should be seeking help, just like you would be saying with a 10 puffs of salbutamol. We are calling 999, help is coming to us. And I've seen a really depressing amount of cases over the last few years where young people have been put in the car or tried to get themselves to hospital and actually have had sort of respiratory arrests, on the pavement, because the recognition just isn't there. And, as we said already, they're the children that die because the recognition of the fatal attack just isn't there. Hopefully that's clear. Excuse me. And again, I will try and pop some of the plans on the chat, but they're super easy to find. And actually, the asthma and lung one is fantastic. I put a link to the asthma healthcare professionals page at the end. In terms of our risk profile of our patients, MART therapy is especially useful for people who overuse salbutamol. And that's whether it's appropriate or not. So whether they are overusing it because they're very symptomatic, in which case we need to be thinking about the preventer anyway. And largely a lot of that will be done to modifiable factors, adherence, technique, etc. So by the nature of changing to something like MART, we're negating the risk. But also those who are inappropriately overusing their salbutamol. So the patients who are perhaps taking it for feelings of anxiety, things that aren't asthma. Or some of our patients they feel it's a bit of an emotional comfort blanket, they're using it inappropriately because they've got this feeling and they don't really know what to do. Patients who don't adhere to their preventer but use salbutamol, sounds familiar, doesn't it? That's probably most of our cohorts, certainly in the high-risk category. They're choosing between their preventer and reliever, and therefore they're just going to be using their reliever all the time. We are removing the option to vote with their feet, and we are saying if you are going to be using a reliever, you're also going to get a dose of preventer. Yes, it is probably a bit sneaky, and I will quite happily say to a young person, I'm being sneaky now, I'm going to take the choice away because I'm concerned that you're overusing salbutamol. If you have symptoms, you have to take the medicine that's actually going to improve the inflammation. We've also got the patients who, as I've said, might actually have really good adherence, really good motivation, but are not using the device as well. And the classic for that with young people is using a PMDI without a spacer. If they can demonstrate a good inspiratory drive, i.e. use the device correctly, they will get good lung deposition versus an MDI. Sorry, this is blue. I don't have a brown one with me. 70 to 90 miles an hour straight into the mouth is just not going to get into the lungs. It's going to stay around the mouth. And there's some really fantastic images that I use in my practice to show that it just stays here. Last but really not least, and certainly in our patch, we have lots of families, lots of young people that really struggle to form routines, whether that's because they have some delay, they have some complex needs, whether it's just chaotic family life. We've got lots of families that are under lots of stress. There's lots going on. We've got multiple jobs. We've got multiple generation households. Struggle to actually remember to give the medication. It's not an easy thing to do. I have a kid with asthma. It's really hard to remember. But also notice when the medication is empty, most PMDIs don't have a dose counter. And until we've been nationally with a campaign to that, that's going to be a problem. These do. So again, it's a really good safety net, if you like. And the other thing to be mindful of, and again, in a lot of our deprived populations, it can be really apparent with the chaos as well. There are some young people, but there are also some parents and carers, perhaps our neurodivergent parents or young people who pathologically find it difficult to form a routine. They cannot remember. They have to really have lots of systems in place to remember. Again, this sort of, it's not going to make you remember, but if you're taking it when you're symptomatic, we've got that safety net. And again, the dose counter is a really good way of remembering whether you've taken it or not. Top tips for introducing MART. First and foremost, I think I've alluded to this already. Introduce it as one option. So we can do our usual thing of talking about asthma, talking about prevention, talking about what keeps you safe, i.e. getting the medicine from here to down here. And we can talk about, how the young person is using their medication or not, as the case may be. And what I quite often do with young people, because the classic patient who would really benefit from MART, but also might be anticipated as being a tricky sell, is the patient overusing salbutamol or just not using a spacer. You can say, and I do say this quite often, and it usually goes down better than you'd expect. You can use this if you prefer, but I expect you to use this with it. That's my expectation. I will nag you. I see you. This is the way it will get into your lungs, and this is the way to use it safely. Or you can have this, and these are your choices, and you can almost sort of lay them out on the table. There are obviously other devices that you can choose, things like rubber ellipta, other things that are licensed, and perhaps other options for your patient. But for MART, this is our choice. And you'd obviously have more than one inhaler. You'd have two. Tangible benefits, and one of these has been mentioned loads by our CNS teams. So obviously we've got no spacer, so no nagging, win. This fits in the blazer pocket really well, it fits in a handbag really well, it fits in your football or rugby shorts pocket really well. And again, a lot of our young people will that's the time when they don't want to use it. They don't want to use it at school, they don't use it for sport. It will work just as quickly in response to symptoms, and that's a big worry. And we are sneaky, we're jammy, we're treating inflammation while we're treating our symptoms. And it's one device. You can be a big nerd and say one device to rule them all. We've also got a dose counter. Okay. Excludes my front door. In overview, we've got these pros. So we've got one device equals no choice between prevention and rescue. It's low risk. We've got limited options, which is great. We've got a dose counter. And of course, we've got a lower carbon footprint. We've not even touched on that, to be honest. We've obviously got a lower carbon footprint between this device and a PMDI anyway. But actually, if your patient is better controlled, and there we need to trust the science that they're preventing as well as relieving, a better controlled asthmatic has a much lower carbon footprint than somebody that's seeking help all the time, going to hospital, having ambulance trips, etc. Cons, we've talked about already. Patients will need training. Some are trickier than others. Some are trickier to sell it to others. and adherence can still be an issue, but of course we've got that safety net that they can't choose just their SABA. So at this point, I'm just going to pause and move on to some case studies. While I do that, has anybody got any questions? Fab. I realise this is quite fast. I'm sorry. So case study 1, I've got a 12-year-old boy that's come into your GP practice for a post-attack review. And as you know, the new guidance is it's within 2 working days. So this could be anything between 2 actual days and maybe a week, depending on where it sits. The prescription is as below. So we've got Salamol PMDI, PRN, we've got Soprobec 100, 2 plus BD. They've had 8 salbutamol and they've had 3 Soprobecs in their last 12 months. And that's quite often the first thing I do when I review a patient in primary care in our joint clinics. We'll look at the uptake. And they've also got an air chamber with a face mask. So that's the yellow one with the teddies on. So just bear in mind the age. History, they're pretty atopic. They've had infantile eczema, CMPI, allergic rhinitis still. They were coded as viral induced wheeze since they were about 4, and then eventually were diagnosed with asthma. They were on Clanor 100, which was stepped up last year to 2 puffs BD, and then the brand was changed to Soprobec. So they've had a little bit of a change in the past. And they are quite an anxious young person. They're referred to CAMS and rejected, unfortunately, because of the threshold wasn't met. And they were actually signposted to Cooth in the end, which, if you're not aware of, is a really great resource. This is a real patient. Obviously, it's just anonymised. When they come into the room, they appeared really well. You've done all of the usual things. You've assessed them. You've done their observations. You've had a listen to their chest. You've established that they're recovering. They've finished their oral steroids. They're recovering really well. They're not wheezy. They're not working hard, and they've taken a reliever a few hours before. But you're kind of happy that they're okay. They're not really needing their reliever very much. The conversation, of course, then moves on to the attack itself, the triggers, what happened, and preventive therapy. So, as is quite often the case, and this is why I chose this patient because it's kind of a textbook one, they're taking their preventer sporadically, which is evidenced by only having 3 in the last year. If they're having symptoms, they tend to remember, but they're not taking it regularly enough or for a long enough period to actually be getting any benefit. And I can say that to patients, and you can certainly say that as well. It's a small dose. It works over time. It takes 4 to 6 weeks to really work. When you're taking it willy-nilly and for a couple of weeks at a time, it just doesn't do its job. They report using a spacer sometimes, but it's a yellow mask air chamber, so they're not keen, unsurprisingly. They're using the rescue inhaler quite a lot, as evidenced, again, by the fact that you've got 8 in the last year. They're coughing with high pollen, high pollution days when the weather changes, but they're also coughing when they're laughing. Which is a big red flag. But they're also coughing at these time-stamped intervals, which we see quite a lot at the school gate and in anticipation of social events. So again, have a think about what you think that might mean. This is the asthma control test, 14 out of 25, which is really poor, of course. And I'd actually argue, hopefully you can see this because it's fuzzy on my view. This is the real asthma control test for this young person. I would actually argue that it should be less because they're not well controlled. They're slightly, perhaps slightly delusional about their symptoms. So what do we need to know about this patient? I'm going to whiz through, and please do add bits into the chat if you want to. We need to know whether they're having symptoms or feelings. They're anxious. So it appears to me, and this real patient was like this, they are having pathological, real symptoms where they're wheezy, tight. If you did a peak flow, it would be low because they are tight. But they're also having feelings, so feelings of anxiety that can quite often be muddled with a feeling of asthma. And it appears they're using their blue inhaler for both. So they're using it appropriately and inappropriately, but actually on a background of really poor control because they're not adhering. We can help them to unpick which is which, but that's a long game. That's going to take a little bit of time, and we can use things like peak flow diary, symptom diary. Digital Health Passport has a good symptom mapping feature. And actually, we also need to know about their device. Would they actually use a spacer if they had an appropriate one? Or is it just a no-go? So with that in mind, what would MART add? So they wouldn't be able to choose the blue inhaler anymore. If they can actually use the device, of course, they would be kind of forced to choose prevention as well as symptom relief. And they would sort of self-titrate their reliever use to severity, of course. If they're having lots of symptoms, they'll be using it more. And actually, that's kind of what they're doing already. They're using their preventer only when they've got symptoms. Even if they use this a little bit too much at the beginning, when they're first sort of embedding it in their routines, they're going to be receiving more inhaled steroid than they were before. and by the nature of that, kind of treating themselves. What would you do? So actually we moved them onto MART. They were really pleased. They were chuffed to not have a spacer, chuffed to not be nagged. Really, really pleased. Another quick one. We had a 15-year-old next who came in for annual review, hadn't been seen for about 2 years. And again, this is a real young person. Medication uptake is on the page here. So pretty poor Sopra-Beck uptake and none at all for 6 months. Had requested 2 salbutamol MDIs in 12 months. They were both in September. They were both in anticipation of the school year. One was for the school bag, one was for the football bag, with a spacer, very conscientiously. But actually, the young person wasn't using a spacer. The person in fact had assessed them. They'd had excellent technique. They're just choosing not to. They were a really high achieving football player and just simply didn't want to. She never had symptoms. She never needed her salbutamol. Couldn't remember the last time. And actually, as I said, playing football at a high level, twice a week, plus running, plus PE, really active. So this is her asthma control test. It was 21 out of 25, but actually, again, this is why asthma control is a good tool for discussion and not necessarily an exact science. Once or twice a week being short of breath actually turned out to be puffed out because she was working hard at sport, not tight. And I would argue, similarly to the other person, that she was actually very well controlled. So it should have been maybe 23, 24 out of 25. With this patient who's basically having no symptoms, never using salbutamol, and actually it sounds like potentially is on the cusp of potentially even being de-diagnosed, what else do we need to know? So we want to just check there's no other symptoms, there's nothing sort of muddying the waters. We might want them to do a bit of a symptom diary, but actually, essentially, she's having none. And actually, it might be that we plant the seed that she might not have asthma anymore. And actually, eventually, she may be sort of de-diagnosed, if you like. What would MART add? So it would add a safety net, but actually, is it necessary? And actually, for the case of this patient, we talked around it for a long time, and it wasn't. We started her on air therapy, so we almost stepped her down to anti-inflammatory reliever with the proviso that if she needed a reliever dose at all, she would be coming back to the practice. And we really did weigh up the pros and cons, and it was a really interesting conversation. And I absolutely had to eat my words because I'd sort of said I'm a little bit cynical about air. I just wonder if that's something that you would be comfortable doing in your practice. Please do add sort of anything in the chat if you've had this in your experience. So in summary, MART should be considered as first line for young people who are able to understand the premise, understand the plan, use the device. And we just have to be really careful and consistent when we think about initiating the regime, considering self-management. We want to make sure our patients are informed. We want to make sure that they're making the choices. And actually, as I've said, there's a real proviso here that if they're happy with their device as per the old guidance and they're using it well, we are not going to just be switching. And finally, I was told this by somebody from Asthma and Lung a while ago, we trust the science. We put the blue inhaler in the bin and we trust the science that this works. And it can be really uncomfortable at the start, but it is something that our local teams are more than happy to support you with. So all of you, sorry for the Kent people, all of you in North East London will have a borough or a place asthma nurse that's more than happy to support you. I've got a couple of pages of resources, but just before we do that, I'm just going to pop up a little feedback QR code. There is also a link, which I'm just going to pop in again. It really is valuable. I'm trying to kind of show that we need to do more of these sessions. So please do fill it in. Really honest feedback, really gratefully received. Resources. So you've got your local asthma team. You have somebody everywhere. Please email me if you don't know them. We have a Pan North East London patient information booklet. Again, the link is at the top. We've got those booklets translated into 15 languages, so please have a look. It's on the KEG template, but it's also on your primary care portal. On top of that, we've also got some educational animations for asthma, so on the 5 basics of asthma care, and for allergy for schools and for non-clinicians. We've got PCRS who are fabulous. We've got Right Breathe, as I've said, if you're not aware, definitely download it or have it on your tabs. Asthma and Lung actually have a new healthcare professionals portal for children and young people. They've actually kindly sent me over a slide, which I'll show in a minute. PCRS have this really brilliant infographic, like I've said, including a switching guide. I've found this really helpful, and I know a lot of my colleagues have. Asthma and Lung Professionals Hub, brand new children and young people's page that's got lots of really great information on. And finally, before I finish, 2 minutes late, if you haven't done your tier training, please do it. It's not my rule, it's not me nagging. It's an NHSE monitor thing. I know I got a little bit stubborn when I did the questions on Eventbrite. CQC are checking, they are actively looking when they come into practices now and come into units. It's been added to the NHS system requirements. Check which tier you fit into. If you're a clinician, you need to do at least tier 2. And actually, if you are prescribing for asthma, just go straight for tier 3. Again, all the links are in the chat. I'm going to stop sharing and just wait for a few minutes for questions. Yeah, thank you for coming. Please do consider doing the feedback. Oh, thanks everyone. I've got a question here. Can you explain the asthma control steps? What do you mean? Do you mean in terms of the different steps of therapy, stepping up and down? Oh, I don't know if it's still here. How to use an acute exacerbation? Yeah, it's a really tricky one, isn't it? So essentially what we're going to be saying to our patients, so I think this is Shamira, I think. Oh, from Chris Street, hello. So what I say to my patients is essentially when you would reach for your blue inhaler, we're going to reach for our turbohaler instead, and we use 1 puff at a time. And you can use, if it's an emergency, you can use up to 6. I mean, it is actually all in this guide, which is really helpful because it is a bit of a thing to get your brain around, isn't it? We use 1 puff at a time. Something that we've been talking about quite a lot. Like I said, this is the 8th session. We've had some really interesting questions. Is when would we prescribe a salbutamol alongside? So generally speaking, the rule is we just have this, we have no blue inhaler. There is kind of an addendum to that. So if you have a patient that is on MART but has anaphylaxis and the blue inhaler is part of the anaphylaxis kit, would be wanting to prescribe this as well for that instance, because of course you've got sudden onset breathlessness because of an allergen or anaphylaxis, you're not going to necessarily be able to do this. Here we go, smell it, right. So yeah, if we think about the steps of asthma care, of asthma treatment, sorry, let me just go back to the slide. Here we go. So we've got quite a lot going on this slide. You would essentially, with MART, you would start with, let me get my pointer. The guideline says you could do just air therapy in the first instance, but actually, if you are seeing somebody and they're newly diagnosed and you are seeing them because they have a concern, they're not going to be asymptomatic. So you would want to be starting them on low dose MART. So i.e. 100 over 6, 1 puff twice a day. That would be sort of the lowest dose MART you can do. And then if they're poorly controlled, despite good adherence, checking all the boxes, they're taking it right, they're taking it regularly, etc. You can then step up. So you could do you could do 2 puffs a day. But then when we do get sort of past moderate doses, we would want to be referring to a specialist. Hopefully that's helpful. I'll see if I can find some other resources to send to you. I can't see any more questions. I don't know. I know there are lots of visuals. I do like a visual. I will try and attach these slides to the chat, but Teams doesn't like it very much, so I might just have to pop the link to the OneDrive instead. Let me just see if I can do it while I think about it. There's so many chat bits here because this is the same one for every single session. Where are we? And if your practice or your area does want any more support with MART, because it is tricky sometimes, you do have a local CNS that would, I'm sure, be very happy to support you. I definitely put it on here. Did I do it on the first one? I'm just going to stop recording while I talk to myself. Sorry.